Hey everyone, I hope you're doing well. It's Friday, and that means it's a compilation video for kind of the topics that we discussed over the week, and that has been vestibulitis. Now, I did receive a couple of comments about kind of some of the thumbnail images I put on Facebook saying, hey, I don't want to scroll through Facebook and see a vulva, so I'm going to try and make sure to keep those, I guess, a little bit more G-rated for people. Obviously, being a gynecologist, this is a normal thing for me to see, and I always try and do things as tasteful as I can, but, I obviously don't want to offend anyone either. So my apologies if that was offensive to you. So that said, kind of moving on, just in general, vestibulitis is basically kind of an umbrella term for inflammation or infection even of the vestibule. And the vestibule is a collection of tissue that is rich in both estrogen and androgen receptors located about midway from the labia minora to the hymenal ring, and extends all the way up to right by the urethra on both sides, and it encompasses the tissues of the periurethral glands, which is, if my face in this video is the urethra, the periurethral glands are like right here. And it goes kind of all the way down to the bottom right of the entrance to the vagina in an area what's called the posterior fourchette. And the vestibule, like I said, has a couple of different hormonal components that make it a little bit more interesting. And so just doing estrogen therapy for vestibulitis often doesn't treat the whole problem if it's a hormonal issue. And we'll talk about this more in detail here in a little bit. But the reason that the vestibule has those androgen or those testosterone receptors is because it is an embryologic equivalent of the area of the urethra that comes out of my prostate. Or a male prostate, I should say, not just mine, but male prostate, which obviously is very high in testosterone receptors. And so kind of as the fetus develops and sexual differentiation occurs, you see the migration of some of those cells is present. And if you want to know more about the actual anatomy of this, if you go to my website, which is just corybab.com, on the blog section, I put a whole big blog about the vestibule from kind of more of an anatomic term. So anyway, let's move on to vestibulitis. So we talked about vulvodynia and vestibulodynia last week. And so vestibulodynia is basically an umbrella term for pain in the vestibule. Well, vestibulitis kind of is a little bit more focused in there. There are three main subtypes of vestibulitis. Now, there are other things out there, but the three main ones we see are going to be either hormonal, neuroproliferative, or inflammatory. Now, other things can cause pain in the vestibule. Pelvic floor dysfunction, 100% could definitely do it. But as far as an actual aberration with the vestibule itself, that is not due to the pelvic floor. That is a manifestation of chronic muscle spasms, which is causing localized ischemia, which is decrease in blood flow, which the body then goes and responds by sending out chemicals to try and open those little teeny capillaries at the surface, which makes that tissue appear red and irritated. But it is not a specific type of vestibulitis. Vestibulodynia, yes. Vestibulitis, no. I know it's kind of like nitpickiness, but the three main types of vestibulitis, like I said, hormonal, inflammatory, and neuroproliferative. So hormonal, obviously, we said rich in estrogen and androgen receptors. If something comes along that depletes those hormones in the body, you're going to see a resultant kind of irritation in the vestibule itself. In premenopausal patients, the most common cause of this is going to be the use of oral contraceptive pills. OCPs, especially ones that the progestin in them, most OCPs are a combination of an estrogen and progestin. If the progestin is specifically anti-androgenic, meaning that it lowers testosterone, you're going to see a big reduction in the lowering of a hormone called sex hormone binding globulin, which comes out of your liver, whose purpose is to go around and pick up kind of free or unbound estrogens and androgens and some thyroid hormones, some other things. So those OCPs cause that SHBG to be really high, which in turn says your free testosterone is going to be almost non-existent, and which is going to cause irritation in the vestibule from a testosterone depletion. Hormonal, other medications that do this a lot of times we see are things like a spironolactone or aldactone. That's a medication that is used for acne or kind of unwanted hair, like hirsutism, unwanted facial hair. It was originally developed as a diuretic or water pill. You can still use it for that, especially in certain doses. but that spironolactone basically inhibits testosterone as well. And so if you have a patient that comes in, she says, man, I've got all sorts of pain with intercourse, especially with initial penetration. You do an exam, that vestibule is red and irritated. You say, hey, what medications are you on? And she's like, well, I'm on, a birth control pill, and it has drospirenone. That's one of the big progestins that lowers androgens. Or, oh, I'm on spironolactone. I'm on 150 milligrams of that, which is a anti-androgenic dose. You say, aha, I think we may have the results here. So, obviously, in postmenopausal patients, you're going to have an ovarian reduction in the production of those sex hormones, and so you're going to see a concomitant kind of inflammation of the vestibule there. And this goes for women who go through menopause from having their ovaries removed for like endometriosis, if they go through chemotherapy and they become menopausal, or if they just go through regular old run-of-the-mill menopause. It doesn't matter. They can all be kind of hurt by this hormonal vestibulitis. And this is actually a component of another condition called GSM, or genitourinary syndrome of menopause. And we can talk about that another time. But the gist of hormonal vestibulitis is there is a depletion of androgens and estrogens, and the tissue is crying out saying, feed me, please help me, I'm achy. And this manifests by pain with initial penetration, whether that's sexual or non-sexual. It can present as vaginal dryness. It can present as kind of chronic kind of achiness, or itchy, scratchy feeling kind of in the vestibule there. There's a whole lot of things with it. The way you treat this is you take away the offending agent, if possible, and then you replenish the hormones that are deficient. So typically we'll use either, there's a medication called Intrarosa, which is an intravaginal DHEA. DHEA is dihydroepiandrosterone. It's a precursor hormone. It breaks down into a type of estrogen and a type of testosterone, or type of androgen, and it will replenish that tissue beautifully. If that's not possible, you can do a compounded estrogen, or estradiol, and testosterone, or a compounded DHEA that works as well, and put that right to the target tissue. You want to do that for at least 6 weeks to get kind of an initial burst, and then after that you can titrate as needed. Obviously, I didn't even mention this before, but the way we diagnose vestibulitis, or the gold standard, is what's called a Q-tip test. Basically, when you have a patient kind of in a lithotomy position, that means they're laying on their back and their legs are kind of up in that stereotypical gynecologist position. You take a little cotton tip swab and go around and touch on the vestibule, and if that area is exquisitely tender, then you've pretty much made your diagnosis. So that's hormonal vestibulitis. Move on. Next, we're going to go to inflammatory vestibulitis. Now, inflammatory vestibulitis I talked about yesterday, and this is typically due to some sort of infectious agent that's causing copious vaginal discharge that then is causing a localized inflammation as kind of a response. So women that have chronic bacterial vaginitis, who have chronic cervicitis, will see this. You can have a condition called DIV, or desquamative inflammatory vaginitis, that presents with just this copious, sticky, glue-like stuff. And it just really is irritating to the vestibule there too. Tissue is not, for the most part, made to be wet all the time. And especially if you have something that is, now kind of wet constantly from a discharge, if the kind of pH or acidity level of that is a little bit aberrant, you can have that inflammation there too. Now, the other thing we see with inflammatory vestibulitis is that this may kind of have a little bit of a kind of chronic, reaction, if you will, to specific lesions. So if you have someone that has like one spot on the vestibule that just doesn't go away, and it's biopsied and it comes back, nothing for cancer or things, nothing bad. Sometimes the treatment for this will be using, a steroid cream kind of to that specific area, or you can actually even inject a steroid right into that spot. Inflammatory vestibulitis, typically, once again, you got to figure out what's causing the inflammation. So that's kind of the hallmark thing. So is this an infectious agent? Is this a dietary thing? Is it more of an environmental reaction? Someone who has switched their pad brand, and now they're getting kind of a response to that. If a patient has asthma or they have eczema, you may also want to consider doing things like Singulair, or kind of a mast cell type inhibitor. You can get a mastocytosis, which is a kind of an increasing in and mast cells, which are inflammatory type blood cells, to the area, and the tissue appears very cobblestone in appearance, very what's called hyperemic, kind of swollen. And so medications like Singulair or Montelukast can be really helpful for that. Obviously, some of the big guns for this, if it's really chronic, we'll do a combined estradiol antibiotic and steroid, typically compounded into a suppository form, and placed directly to the problematic area. And I'm going to talk about vaginitis next week. I'm going to talk about vaginal discharge, and I'll talk a little bit more about some of the aberrancies with there, some of the more unique things, but there's a couple of those that can feed into inflammatory vestibulitis too. So the final thing is neuroproliferative vestibulitis. Now this is kind of I think the most interesting one in terms of pathology. So there's two main subtypes. There's either a congenital, which means you were born with it, or there's acquired, which means that at some point you developed this type of vestibular inflammation. For congenital neuroproliferative vestibulitis, these patients typically will say, hey, you know what, I never was able to really ride on bikes as a kid. Going on sliding down a banister or anything that's causing constant pressure to that genital area was uncomfortable. As I mentioned before, around 60% of these patients will also have umbilical hypersensitivity. So your umbilicus is your belly button. So if you go stick your finger in your belly button, most people are not like, oh, wow, that feels great. I mean, maybe there's some people are, and that's fine, judgment-free zone. But for these patients, they're like, ooh, yuck, that feels gross. Please don't do that. I don't like that. It feels really bad. And so it's kind of this hypersensitivity type thing. So like I said, that's present in 60% of patients with that. Acquired neuroproliferative vestibulitis results from some sort of insult to the vestibule. And that's typically been related to something like a yeast infection that went untreated or things like that. And what happens in neuroproliferative vestibulitis, or both types, is that the nerves kind of proliferate. They get a lot more, and they migrate much more superficial in the vestibular tissue, so they're much more easily irritated. And remember that nociception, kind of the way we perceive pain, the most basic form of nociceptive activity is itching. And so this will typically have kind of an itching, a very mild burning, things like that, as those nerves are just constantly irritated. So for acquired neuroproliferative vestibulitis, like I said, you may have been able to correlate it with some sort of environmental type, change, an infectious change, something along those lines that caused that trigger or that, switch to flip, if you will. Treatment for neuroproliferative vestibulitis is a little bit more complex. Obviously, if you can find something that is a known trigger and you can take care of that, that's amazing. Do that. We used to compound a lot of kind of vestibular pain creams, which were typically a mixture of things like amitriptyline, gabapentin, baclofen. There's a whole slew of them there. Neuromodulatory medications like gabapentin or pregabalin, which is Lyrica, those can sometimes work too, kind of in reducing nerve dysfunction or nerve pain. But really the big gun here these days is capsaicin. It's the new kid on the block. Capsaicin is kind of the hot agent that's found in chili peppers and things like that. And we'll compound the capsaicin into a cream, and you apply it directly to the vestibule. And you tell patients this is going to feel like someone lit a blowtorch in your genitals. And you make sure they have some really cold water close by, they can wash it off, and you try and work it up so that they're applying this, about 20 minutes a day. In the beginning, they may only be able to keep it on for 1 or 2 minutes, and that's totally fine. But that goes in basically, and that deadens those nerves, and it kind of changes the overall nerve function there. Obviously, if that doesn't work or a patient doesn't want to do that, you can do what's called a vestibulectomy, which is a surgical procedure that we do that we basically just kind of take the vestibule away. And as part of that, we also kind of advance the vagina down closer towards the vaginal introitus. So you really are eliminating any type of vestibular tissue that may be causing problems. So a lot of stuff to kind of talk about there. If people want more information in detail, I'm happy to do that. But anyway, I hope you've enjoyed this overview of vestibulitis. Obviously, if you do, please share it, like, subscribe if you want, all that stuff. Share it with your friends. But I'm Dr. Corey Babb. I hope you have a wonderful rest of your day, and I'll see you again next week. Take charge of your own health.